I want to start our work today really introducing you, Dr. Keshavan, who is really a outstanding full professor at Harvard Medical School, that one of the Stanley Cobb, which is embedded in the public sector and research into mental illness treatment. And, Kesh, you've been involved in working with first episode psychosis, as well as really working closely with those with severe mental illness. And it's our excitement and our desire to really move further and further upstream so that really we meet people as they're beginning to struggle and not wait for them to fail over and over again with inadequate or partial treatment until, the face of mental illness has a look, as it will, with people in their 50s and 60s that all of you see in the course of your clinical work and training. Change the face of mental illness, and I look to Dr. Keshavan as a major influencer in that. And we're glad to have you here to talk about early psychosis and its effective treatment.
Thank you very much, Dr. Sanders and Margaret, for inviting me to do this. This is truly exciting because we'll be talking about the beginning of an illness that could kind of define a course time of life. I am joined today by Bethany Yeiser, who is a young lady who experienced the illness a few years ago and has been in the road to recovery. And I have always learned that the best way to learn psychiatry and medicine is from working with people who have experienced the illness. And so I requested Bethany to tell us a little bit about the experience of the first episode of psychosis and the beginnings of treatment for it for about 10 minutes, so that then I can kind of connect back to all that she says through the rest of my talk. Bethany, I'm going to ask you 3 questions.
Okay.
And we have about 10 minutes, a little less than 10 minutes. And I know you're very, very good in getting straight to the key point, like you did last time. First question is, tell us how you came to accept this illness as a schizophrenia illness, and how you came to accept treatment. And the second question I'm going to ask you is your experience with the medicines, because this is a psychopharmacology lecture, and also how you came to terms with its effects as well as side effects. And the third question is, what should future psychiatrists and other prescribers know in taking care of people with serious mental illness, especially with pharmacological agents? So those are the 3 questions. So all yours.
Excellent. Well, again, thank you for having me this afternoon. I'm very pleased to tell you a little bit about my journey through schizophrenia. I will just open by saying on March 3rd of 2007, I was picked up from a churchyard where I was living as a homeless person. I'd been there 13 months and taken for evaluation in a psych ward. I was absolutely sure beyond a shadow of a doubt that nothing was wrong with me. I thought I was too smart, too normal, and too strong to have a mental illness. I thought that was impossible. And I thought that people with schizophrenia were all locked away somewhere, blankly staring into space. I needed to learn that treatment works on your brain, regenerating the tissue, and can lead to remission of positive symptoms. I needed to learn that if I committed to my recovery, worked on relationships, got back to school, I could have a future. I will also say that March of 2007, after about 36 hours, the doctor told my parents that I was permanently and totally disabled. He said I would not live independently, I would not go back to school, I would not work. This was pretty much the end of my life. That doctor did not say, we will do anything in our power to get you better. If I had had cancer, they might have sent me to a new city for a clinical trial. They didn't say, clozapine is an option if none of your other medications work. Just looking back, I experienced a wonderful childhood. I think I can say no significant drama. I was very involved in practicing violin 4 hours a day, Cleveland Orchestra, Youth Orchestra, taking college classes while in high school. My dream school was the University of Southern California. I got there in 1999. I was extremely busy. I was taking hard classes, doing research. I was concert master of the community orchestra. But at the same time, I could not interact with friends normally. It was like this mania. I could not stop studying and researching and practicing the violin. It was like a shadow had fallen, but we had no idea that having this life out of balance would eventually lead to full-blown schizophrenia. So my life was the lab. Then I started to lose interest in the lab, which didn't make any sense. Then my grades started dropping significantly. The fall semester of my junior year, 9/11 happened, and I started to feel I had a new mission. I wanted to win a Nobel Peace Prize, and I was convinced I could only do that through traveling the world, learning about other cultures and ways of life so that I could make this, as I thought, this worldwide impact. It was just a passing thought at first. Went to China. While I was there, I started to think, can I help millions of people living in China? I thought, yes, I'm sure I can. I didn't think I need more schooling. I need to study Chinese. I just thought that somehow I would impact millions of people immediately with little to no effort. I got back from China. I went to Africa, was there for 2.5 months, loved it, learned a lot. And then I was back at USC. It was my fall semester of my senior year. Took my first exam and I thought I aced it. I was back. Things were going well again until I got back this exam, which I had failed because I had essentially written gibberish for all the answers. My mind was like this cloud. My mind was like this broken old-fashioned record going back to Africa again and again, and I could not move on. So here I am failing my classes and telling myself, I'm not trying. I could do this if I wanted to, but I'm the next Mother Teresa. I don't need this degree. My parents were concerned, as you might imagine. They didn't believe I was going to be a prophet and a billionaire, and I was so offended by that and so paranoid of them for no reason at all. I failed my classes. I took a trip to Thailand. My host family there called my parents saying something was wrong with me. And then when I got back from Thailand, started planning a trip to Saudi Arabia. About that time, I moved out of the dormitory, started living in the university library. I had a valid USC ID. I slipped through the cracks. And my homelessness started March 3rd of 2003. On January 28th of 2006, sitting on a park bench in the university when I started to hear this chorus of voices inside of my mind. There was a young woman coming out of the chorus, a young man. Eventually I would hear police officer, my future husband, a loving grandfather, all kinds of characters. About that time, I was taking a shower at a friend's apartment, and there were 3 guys who I thought were able to see me through the window. I knew because of their very specific derogatory comments that they could see me. So anyway, I get out of the shower to see these 3 guys, and there's no window. So I'm looking for a sunroof. I'm just wanting to see these 3 guys, and there was no sunroof. And it took me a few minutes before I realized that those guys were actually not there. Started having visual hallucinations. One day I looked in the mirror and saw my reflection, but it was a cross between me and the character Lisa from the show The Simpsons. When the voices came on that January of 2006, they kept bothering me about sleeping on campus and libraries and lounges, probably because they picked up on the fear I was experiencing that I would be noticed or caught. So I decided to start living in a churchyard outside as the voices got worse and worse and worse. It took a few months before I started to hear command hallucinations. They would tell me initially to scream, 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 scream louder and louder until I would just scream, trying to appease them and get them to go away. I'll just share briefly. Before I started telling my story in 2014, years before that, I went to a party where I met a law student, and the topic of voices came up, and she said, people who hear a voice are culpable for their behavior because they hear the voice and they can just choose to do what the voice says or not do what the voice says. Okay, that was not my experience. It was like those voices in their annoying way could make me do anything. I recently corresponded with a mom. Her daughter set herself on fire because the voices told her to. Amazingly powerful. Anyway, the voices changed my behavior. I started screaming, walking in strange patterns, hitting myself. And on that fateful day, March 3rd, 2007, I would be picked up by police and taken for evaluation. The worst day of my life, but the day that I am the most grateful for. So they started me on risperidone. They told me you can have a shot or pills. You have no other choice. So I was on it. And guess what? A miracle happened. The voice had said scream, and I thought to myself, no, I don't think I will. I had control over the voices. My visual hallucinations stopped. My tactile hallucinations stopped. I was doing way better. My behavior was much more normal. I didn't notice any change at all. And in the back of my mind, I'm still hearing voices. They're not telling me to do anything, but I can't read because these voices are so bad. At least I cannot remember what I had read. I could read much better. So anyway, it was time for me to go home as my behavior had changed. So I flew back with my parents to Cincinnati from Los Angeles, where I had been at USC and then been homeless. And I had late onset side effects from my risperidone. When I got on risperidone, I was terrified it would cause me to stare into space, be like a zombie, but it was 10 times worse than I would have ever imagined. I had severe akathisia. I wanted to just jump out of my skin. I had anhedonia. I could look at my favorite picture and feel nothing as though I were blind. I had weight gain, voracious appetite. I remember one of my doctors saying, just stop that and, eat healthy food. Prior to my diagnosis, I used to fast. And after 24 hours, I was really hungry. When I was on risperidone, I'd eat a huge breakfast, and within 3 hours, I was hungrier than I had been after fasting. It was uncontrollable, and I'm sleeping 16 to 18 hours a night and waking up exhausted. And I thought, I don't need this medication. I'm strong. It's not doing anything. I can handle myself without it. So I did the reasonable thing. I went off my risperidone. That's when the command hallucinations came back. I should say at first, I felt so much better, but the command hallucinations again, they were back, and I was acutely psychotic, which culminated in breaking a very valuable violin, which was my treasure because the voices told me to. I'm taken to the hospital again, my first Ohio hospitalization. They put me back on risperidone, and I met a doctor who told me, do you want to go back to school or play violin at a high level again? He said, that might be possible, but you must always take your medication. He told me something I wish I had known on day one. If you go off your antipsychotic and on it again, it can be less effective or even ineffective forever. I would like to encourage all of you today to tell that to your patients immediately. If they're not paying attention, staring into space, still try. Because this is what leads to disability in schizophrenia, non-compliance with medication. Another wonderful option you all have that is so underutilized is long-acting injectables. I currently run a foundation with Dr. Henry Nasrallah. We have the honor of having Dr. Keshavan on the board. Dr. Nasrallah has done extensive research about how people who get on LAIs early do remarkably better. So that is so important to know. I was actually on an LAI during my first Ohio hospitalization. And they told me I was on the LAI because I was a bad patient and a bad person. And so now I needed to basically be punished by getting these shots. wrong perspective here. Don't tell that to your patients. It's not fair. Tell your patients that this is a great option. It's convenient. You don't have to remember to take the pills. You can forget all about the schizophrenia stuff. You just need to come in for the shot. Anyway, I spent 12 months trying 5 different atypical antipsychotics. And it really looked like my first doctor was right. I would be permanently and totally disabled. That's when I met Dr. Nasrallah, who introduced me to clozapine, which I should have heard of before, but had never heard of before. You all know clozapine, so underutilized. 1 in 3 qualify, 1 in maybe 20 to 25 actually get to try it. What that means is you got people living in the community, many are permanently and totally disabled like me, and they haven't even heard of clozapine, and it might bring them back to their baseline. Of course, I'm told with clozapine, I need this weekly blood draw. I can gain 50 pounds. There could be constipation and sedation. It didn't matter. I was doing so poorly. I had no meaningful life. So I started it, and as it happens, I was a clozapine responder. I've been on it for 15 years. During that 15 years, I graduated from college magna cum laude in molecular biology, just like I had once dreamed of. I published a memoir called Mind is Strange, 2014. In 2016, Dr. Nasrallah and I founded the Cures Foundation. And we're big advocates of doctors doing everything in their power to give their patients the best quality of life possible. I would encourage each and every one of you on this call, do not lower your expectations. Always be professional. Try to reach out to your patients. And if I'd like to give you some advice, I would again remind you that patients need to know the consequences of going off their antipsychotic, that it can lead to disability, relapse, poor outcomes. So that is my story.
So that's Bethany Iso you just saw and met her. I'll take the next 25 minutes or so to take you through a quick tour of how we take care of someone with the first psychotic episode, like what Bethany described, and like what this young man I saw in medical school experienced. First of all, there have been many paradigm shifts in the field. The first and most important, one of the most important points for you to take home from today is that medications alone are insufficient. Medication treatment embedded in a coordinated care program that involves psychotherapy, group therapy, family treatment, integrated medical and behavioral health care, supported employment, substance use intervention, peer support. The treatment is most effective when it is done in coordination with a multidisciplinary, multi-element care, which is what we call coordinated specialty care, which DMH has taken really a national level leadership role in building these clinical services across at community levels, at state levels, and so on. The second general point I want to make is that as a medical student, I grew up learning that psychosis is due to too much dopamine. You just hit that dopamine with a dopaminergic blocker hammer and the psychosis will go away. The picture has become a lot more complicated. There's not just one kind of dopamine, mesolimbic dopamine, but there is also mesocortical dopamine, which is important for cognition. Now, the dopaminergic balance is not working in and of itself. It is regulated by 2 other neurotransmitters which work like the yin and yang in the brain. One is the excitatory neurotransmitter called glutamate. If the glutamatergic function, the system is not functioning right, it puts the dopamine system into imbalance. Now, the glutamate system itself has to be regulated. The yin has to be balanced by the yang. So for that, we have the GABA system, which is in blue there. So GABA and glutamate, GABA is the inhibitory system, glutamate is the excitatory system. They work the reciprocal way to regulate the neurochemical balance in the brain. So just the main take-home point here is that the neurochemistry of schizophrenia is a lot more complicated than just dopamine. Newer medications are being developed that work on many other neurotransmitters, including glutamate, GABA, acetylcholine, cannabinoid system, and so forth. The third main point I want to make as a general point is that the most important thing at the beginning that we have to set up is an appropriate comprehensive diagnosis to derive an accurate diagnosis. So you want to rule out substance abuse or medical illness or a developmental disorder to begin with, before concluding that someone has a primary psychotic disorder. If it is a primary psychotic disorder, see whether it is accompanied by prominent mood symptoms or not. If there are prominent mood symptoms, either it is schizoaffective disorder where there is some psychosis outside of the affective syndromes, or primarily a psychotic depression or psychotic bipolar disorder. If it is primarily a non-affective psychosis, one needs to make a distinction between those with systematic non-bizarre delusions, which we call delusional disorder, or those without such non-bizarre systematized delusions, a chronic psychosis, in which case duration of the illness becomes important. If it is less than a month, we use the term brief psychotic disorder. If it is 1 to 6 months, we use the term schizophreniform disorder. If it's more than 6 months and there is a functional decline, we use the term schizophrenia. So this is the approach to differential diagnosis. And of course, there is always a category of atypical psychosis or psychosis NOS. Good psychiatrists and other clinicians use that very sparingly, that terminology, because in most cases, good diagnosis, good history taking should be able to give us the diagnosis. Now, the fourth point I want to make is about how do we work up a patient with first episode psychosis. If it is a typical patient with a first episode of psychosis, there are some things that one would always want to do as a basic workup, and that includes a detailed history, a neuro exam, a psychopharmacological history, including history of over-the-counter medications, concomitant medications, a urinary drug screen, vital signs, basic labs like renal and liver function, glucose and lipid profile, and a CBC. But in certain situations where there is an index of suspicion is higher for something else in addition to or rather than a primary psychotic episode, one needs to conduct alternative or additional investigations. For example, if it is a 38-year-old gardener with a first psychotic episode in Massachusetts living in the rural area, you would definitely want to get a Lyme test. If it is someone with a first psychotic episode and has a history of seizures in childhood, you would want to do an EEG as well to rule out temporal lobe epilepsy. If it is a 40-year-old woman with a new psychosis, has some fever, autonomic imbalance, and a prior history of ovarian tumor, the answer comes quite clearly to your mind. You want to get a lumbar puncture and anti-NMDA antibodies. NMDA encephalopathy is a increasingly well-known cause for a psychosis, initial psychosis presentation. A 41-year-old with new onset delusions, blurred vision, and headaches, you would definitely want to get a brain scan. A 35-year-old woman with a psychotic illness and a bone pains and a low bone density, you would want to get a prolactin level. So there are some things that are routinely done in everybody with a first episode psychosis, and some others which are somewhat more expensive would be based on clinical judgment. The fifth point I want to talk about as general consideration is Bethany made this point very well. The first psychiatrist that she saw said you have an illness that is going to be there permanently, and you won't be able to work or get on with your musical career and so forth. You would not want to go that path. All patients deserve to be given a hopeful message. And in 40 years, what I have learned is that schizophrenia is a hopeful disease. if well treated from the beginning. So we came up with a few guidelines as to how to talk to patients and families about their illness, individualize the approach to talking about the illness, use non-stigmatizing, normalizing words, choose the appropriate setting to talk about the illness, including family, ensuring confidentiality. Use a person-centered perspective, respecting the individual and family's values. Provide accurate and comprehensive information. Provide lots of material, that is accurate material. Provide reassurance, repeat as needed, and respond to questions. And empathize and empower the individuals with the illness. And finally, no such discussion would be complete without giving them a hopeful next step. Now, this can be, we can deal with this. This is what you do, and so forth. That's always a good thing. Moving on to the actual treatment with pharmacological treatment for a first episode psychosis, a few questions become very important. What do you start with? How do you titrate? How do you maintain? What do you do when things don't get better? What do you do when side effects emerge? And what do you do when treatment non-adherence is an issue? I'll go a little bit quickly about the different medications. You would have heard about this in several other places. There were the first generation antipsychotics going back to the 1950s, which were like haloperidol and chlorpromazine and so forth. They all did one thing. They all blocked dopamine. They all block dopamine more than 65% of the receptors. This is what you see in this red line. If you cross that red line, you produce benefits from psychosis, but you also produce what we call extrapyramidal side effects. Remember Bethany mentioning her, she was feeling like jumping out of her skin, couldn't sit still. That's akathisia. It's an extrapyramidal side effect. Now, the second generation drugs came in the 1980s, which had one property, and that is they worked on serotonin as well. So that protected against extrapyramidal side effects. So you have a number of these options that are available, starting with clozapine, which we'll tell you a little bit more, and with lurasidone, ziprasidone, and so forth. So these are dopamine serotonin antagonists, though they manage to treat psychosis with less than 65% blockade of dopamine receptors. Then came the third generation drugs. These are called partial dopamine agonists. They work again like a double-edged sword. Too much dopamine blockade may cause extrapyramidal side effects. A little bit of dopamine is actually good for negative symptoms and cognition. So aripiprazole came in, which is a partial agonist. It stimulates dopamine in the prefrontal cortex and blocks dopamine in the limbic system. And then came a few others like brexpiprazole, Rexulti, cariprazine, that is Vraylar, and lumateperone came in the last few 3-4 years, which works on dopamine and glutamate and serotonin. So they all have their interesting benefits, and some of them are still so new we don't know how well they will do down the road. Now, how do you choose an antipsychotic drug for a given patient? Of course, studies have shown, like the KT study, that most atypical antipsychotic drugs approximately work similarly, with the exception of clozapine, and they work as well as first generation drugs do, but side effects differ, and we'll tell you in the next slide or so. If someone is there in whom the weight gain is a problem, you would want to choose some of the drugs like lurasidone or cariprazine, or even some old drugs like perfenazine. Someone who is a college student, doesn't want to be sedated, has an exam coming up, you would want a more activating drug like aripiprazole, cariprazine, lurasidone, and so on. Someone who is acutely agitated in the emergency room, you would need an old drug like haloperidol, or even some of the newer drugs like ziprasidone IM or risperidone M tablets, or asenapine sublingual, and so on. If it is someone who has not been responding to at least 2 antipsychotic drugs, clozapine is an option. We'll talk about it again in a few slides. Someone in whom adherence is an issue, consider long-acting injectables. When cost is an issue, some of the older medications as well as risperidone might be the way to go. And again, listening to Bethany, it is so important that the doctor and the patient develop a collaborative team. Anything that we do as a one-sided thing is unlikely to work in the longer run. Building a partnership between the doctor and the patient is really the way to go. This is the term we use, shared decision making. How do we initiate an antipsychotic drug? Having chosen a drug, the key principle to remember is start low and go slow. You can go slower in the outpatient than in the inpatient multi-episode patients. And if we already know that somebody has responded to 4 milligrams of risperidone, you can go fairly quickly to 4 milligrams. But in the outpatient, you don't know for the first time, so you'll have to go slower. And then there are going to be some patients in whom the psychosis is not fully established. We use the term clinical high-risk syndrome, also called attenuated psychotic syndrome. Sometimes antipsychotics in a low dose can be helpful. And of course, you would always want to try a psychosocial intervention first and introduce an antipsychotic if there is no improvement. First episode patients respond well to lower doses of antipsychotic drugs. This is something very important to remember, sometimes as low as 50% of what multi-episode patients require. It's a busy slide. I'll skip this. I've already told you that first-generation drugs are particularly likely to cause extrapyramidal side effects. Second-generation drugs, some of them more than the others, like olanzapine and quetiapine, are more likely to cause metabolic side effects like weight gain and risk of diabetes and hyperlipidemia and so on. How long do we continue antipsychotics in a first episode psychosis patient? It depends. It depends on the duration, triggering factors, and response to antipsychotics. If, for example, there is someone who presents to you with a brief psychosis after cannabis abuse and responds very quickly to antipsychotics, that's not someone you would want to commit to a long-term antipsychotic drug. You would want to consider a gradual discontinuation after the psychosis resolves, and of course, after the cannabis problem is also addressed and the patient is sober from substance abuse. Psychosocial interventions are very important. This is an entire lecture separately I can give. There are the treatments of CBT and mindfulness-based therapies and supportive therapy, which are important for psychosis and the anxiety and the trauma symptoms and the depression. Whereas cognitive deficits and social skills deficits might require cognitive remediation, social skills training, metacognitive therapies. Family dynamic issues are addressed best by family-focused treatments. Treatment non-adherence is best addressed by motivational interviewing and community outreach. Substance misuse can be addressed by, again, substance abuse counseling and community assertive treatment. Treatment non-adherence. So this young man who develops paranoid thoughts and hallucinations about a year ago, responds to risperidone, stops meds 6 months ago, had gained 10 pounds. Now symptoms have worsened, leading to his job losing his job as a supervisor in a coffee shop. Now he wants treatment, but wants something else, something other than oral risperidone. So what are the options? Start him back on risperidone, or start another antipsychotic, such as ziprasidone or lurasidone, or start him on clozapine, or discuss with him an option of long-acting. So this is a first episode patient. You would not necessarily give only one option for this person. You certainly could talk about an alternative antipsychotic drug, but always bring up the possibility of long-acting drug. Even if the patient is unwilling at this point, it's better to introduce the idea to the patient. That's what I would do because of the non-compliance issues. Why treatment adherence is important is because relapses are very high, almost 80% in the first 5 years. And it can cause functional decline, inability to regain previous level of functioning. And Bethany said this, if the person relapses, the same medicine may not work as well. the second time. And there could be some brain atrophy as well. There are studies that show that gray matter atrophies over the course of time, especially in those who have treatment non-adherence. Thankfully, antipsychotics reduce relapse rates, and in particular, the long-acting injectables. And non-adherence is extremely common, especially if you do a pill count or even a plasma level. And how does one think about and treat non-adherence? It's important to know what are the factors that underlie good adherence. Treatments that work, have fewer side effects, are simple to use, not so expensive, good doctor-patient relationship, well supervised, good insight, good family support, good premorbid intelligence, acceptance of illness, and acceptance of its severity, and perception of its susceptibility. They all promote good adherence. The opposite of all of those promote poor adherence. So it's important to keep that in mind and consider treatment factors, individual factors, as well as the illness factors. So there are a number of options available for addressing non-adherence. So treating non-adherence depends on the cause of the non-adherence. If the treatment is not working, consider alternative treatments. If side effects are an issue, address the side effects. If it is a forgetting of the medicines or the patient not showing up for appointments, that's where long-acting injectables become an important factor. Ambivalence about taking medications. Motivational interviewing can be quite a powerful psychotherapeutic approach. There is extensive evidence that long-acting injectables reduce relapses by almost 4 or 5-fold. And they also have the advantage that the plasma levels of the medication tend to be smoother, producing less likely side effects with long-acting injectables compared to oral medications. Yeah. Now, there are multiple long-acting injectables available, including aripiprazole, fluphenazine, haloperidol, olanzapine, paliperidone, and risperidone. Long-actings for those with cardiometabolic problems and weight gain issues, aripiprazole is a good idea. And those in whom you want to get very quickly onto the long-acting injectable, paliperidone is a good option because there's no need for an oral supplementation. Those in whom cost is an issue, we may have to go to older medications like haloperidol or fluphenazine. So this slide shows the same thing in a little bit more detail. Paliperidone, especially Invega Sustenna, Invega Trinza, and Invega Half-Era are options available that do not require overlap with an oral medication when you start the injection. And paliperidone injections, so Trinza is available as once in 3 months, and Half-Era is available as once in 6 months. So those are good options. Long-acting injectables are good for adherence. They lower relapse rates. They also don't have the issues of whether there is good absorption through the intestines or not. And if the patient stops taking the medication, it's easy to know very quickly. Now, clozapine is an option when 2 antipsychotics have not worked. But there are some investigators who believe that even after 1 drug fails in early course psychosis patient, clozapine may be worth considering. Just like long-acting injectables, it's always a good idea to talk to the patient about the clozapine option early on itself, even if the patient is unwilling to begin with. A little bit down the road, if the patient already knows about it, more likely to accept. 1/3 of patients with schizophrenia do not respond to conventional antipsychotic drugs. These are the ones that might require clozapine. But even among them, 1/3 of those on clozapine don't respond to clozapine. You may have to go with additional treatments like adding an antipsychotic or ECT as an option. Clozapine also has the advantages of reducing suicidality. It is also potentially, it is probably the only antipsychotic drug which does not, in and of itself, cause tardive dyskinesia, but it has its problems. We have to monitor white blood cell counts because of the risk of agranulocytosis. Here are the side effects of clozapine, which I remember in my mnemonic of A, B, C, D, E, F, and G: agranulocytosis, body weight, cardiovascular, diabetes, epileptic seizures, fever, and gastrointestinal symptoms. Needs a good pre-treatment workup, which includes an ECG, an HbA1c, and also make sure that you get the metabolic parameters to begin with, and an abnormal involuntary movement scale rating for involuntary movements. The monitoring requires white blood cell counts every week for about the first 6 months, and then every 2 weeks for the second 6 months, and then it could be once every month after 1 year. And if there is a neutrophil count reduction less than 1,500, that would be a cause for worry. And if it is less than 1,000, it's a cause for discontinuing clozapine. So 1,500 or below is mild neutropenia, below 1,000 is a moderate neutropenia, and below 500 is severe neutropenia. And there is a national system called the REMS system, that is the Risk Evaluation and Mitigation Program. So those of you who are interested in clozapine would want to learn more about that. So in summary, antipsychotics are the mainstay in the treatment of early course psychosis and best used in the context of coordinated specialty care. A careful diagnostic workup is critically important. Choose the right antipsychotic based on side effect profile and prior treatment response and shared decision making. Use a low dose to begin with and slow titration, and identify non-adherence early and identify treatment resistance early so that you can introduce the powerful treatment options of long-acting injectables and treatment resistance. So with that, I'll stop, and we'll be happy to take 1 or 2 questions, and I'm sure if Bethany is still there, she may be able to answer as well.
I'm back. Yes, I'd be delighted to take any questions you may have.
I have a question. Bethany or anyone else who's more experienced, I was wondering if you could talk a little bit about the process of having a conversation with the service user or patient when they disagree with the clinical team's consensus diagnosis or don't think that anything's wrong. Bethany, I know you touched on this a little bit. I was wondering if you'd share a little bit more about what helped you realize you may have needed help, or the process of becoming more accepting of that.
There's a great resource out there by Xavier Amador. Have you ever heard of that guy? I'm Not Sick, I Don't Need Help. I'd like to first of all promote his book. It's excellent. He talks about the LEAP method, which is listen, empathize, agree, and partner. So that's a great resource. One of the things he talks about is just getting together with a patient and making 2 lists. This is my life when I'm off medication. This is my life when I'm on medication. Just try to help them see this pattern. So I became medication compliant because I finally realized that if I wasn't taking those pills or the shots, I was going to be hospitalized again. And my highest goal was to never be hospitalized again. I will point out that my acceptance of the schizophrenia diagnosis came later, probably a couple months later. So I would say you don't have to go to your patient and hit them across the head saying you have schizophrenia. I think your goal at first is just to get them to take the pills or the shots. Hopefully their insight will follow. But yeah, that was the case for me. I realized that I couldn't live in the community without medication.
Yeah, no, I think no one could have answered that question better than Bethany. But just one thing I could add is that, as she pointed out, treatment doesn't have to wait for acceptance of a particular label. We can work around the label. and we could simply get to what the patient is suffering from and find a point that a plan that addresses that issue. So without even, I have had a number of patients who don't agree with the diagnosis, but I just say, let's work with what you have. So you have a sleep issue. So let's work with how do we get you sleeping better and to get you thinking better, more clearly. And here is something that works. And you don't have to use the word schizophrenia or psychosis in order for us to get an agreement on that.
Real quick, there's a family in Australia. The father contacted me. He has job, house, son. He said, I do not have schizophrenia. It is my choice. I've chosen not to accept it. But yes, I've taken Abilify for 2 years. It's like, okay, he's taking the pills. He's doing well. I guess that's all that matters. So.
Yep. The word antipsychotic itself is stigmatizing.
Yeah.
Many people don't want to take it because it's an antipsychotic. I don't have psychosis. Why should I take an antipsychotic? I tell them, look, you are taking a dopamine antagonist. I don't use the word antipsychotic, period.
And we want to help patients realize that the goal here is to improve their quality of life. We're not here, your doctor's not there to ruin your life. I mean, that's how I felt. Risperidone works wonders for many people. And in a sense, it did to me. But I remember feeling like I was betrayed and lied to when the side effects showed up. And, it took some time to develop trust of my doctor and to realize that the point was to get me a better life.
Well, I want to thank you both very much for this presentation today, and Bethany for your particular direct expression to really allow us to understand your experience. And of course, Dr. Keshavan, great time hearing both your journey, but also how you are journeying with all of us in the knowledge and expertise in first episode psychosis. So thank you very much.